Good afternoon. It's Dr. John Bennett broadcasting from Miami Beach, the Jordan Neurosurgery Grand Rounds. We have the pleasure of having Dr. Subbiah back from a little, he'll tell you about it, what happened. And I'd like to also introduce Radab Tebe. I'm sorry. She's going to help hosting the activities. Hey, hello, Radab.
Hello, Dr. John. I'm very happy to introduce Dr. Subbiah, a professor in clinical neurosurgery from Jordan, who has been and still a well-known neurosurgeon in Jordan and in the Middle East as well. He has been second vice president of the World Federation of Neurosurgery and a very active neurosurgeon currently in the area of Jordan and the Middle East. So welcome, Dr. Subbiah. We are pleased to have you and honored to listen to your presentation.
Thank you very much, Radab, and it's a pleasure to be back after spending 1 month off due to the COVID-19. For those who don't know me, my name is Ibrahim Subbiah. I'm a neurosurgeon from Amman, Jordan, and it's a pleasure to present today something which is really interesting to all of us. This is the Farah Medical Campus in Amman where I work. And I always show you this black iris, which is symbol of Jordan. And as I said, today we will discuss the CNS fungal infection. I will take you through a literature review and I will tell you about my personal experience. And all in all, with all the lectures, we go for clinical, radiological, operative, and pathological correlation. So let me take you through a general look into the virus world, into the fungus world. The countries that are really affected by this fungus are the low-income countries, where they have dry areas and hot atmosphere. So looking into the map, you would see the sub-Saharan Africa, part of South Africa, and the Middle East, and even in the States. So the country which has most of these fungal infection is India. And if you look at how they affect the body, they affect in various ways, whether the skin or the lungs or the kidneys, etc. The commonest affection is the skin. All of us, we see the tinea versicolor and the fungus infection of the hands and feet and so on. And this is followed by the Rhino-orbital-cerebral involvement, which affect the nose and the orbit and the brain, and followed by other structures in the body. So this is a form of the skin fungal infection, superficial fungal infection, cutaneous ringworms, buttocks involved. And look at this is major slough in the skin of this patient, and this geographic distribution of this virus. It can affect the chest, of course, as we said, and here you can see this cavitation here. It can affect the liver, can affect the spleen, can affect the kidneys, and it can affect the sinuses and the teeth. So a very common association of a patient who had a dental extraction followed by a major fungal infection. You can see the defect in the hard palate. So from the sinuses, it can go to the orbit, and then from the orbit, it can go to the brain, it can go to the cavernous sinus. This is the cavernous sinus, and you can see this carotid artery is open, this carotid artery is thrombosed and closed. So brain can be affected badly by these fungal infections. And of course, the spine too. But the brain is more than the spine. So here we can see paraspinal abscesses, psoas abscesses, etc., in the spine. Also, it can affect the bones and the joints. So this is the general look of these fungal infection in the world. Let's look at the morphology of these fungi. They have various forms. And if you look at these pictures, they can present like anything. So how can you tell what is the plan to know what exactly we are dealing with? So people said, well, let's classify them according to the morphology. When they are small, unicellular organisms, we call them yeasts. If they are large branching, we are call them hyphae. And they may have both the yeast and the hyphae pattern, and we call them dimorphic. So yeasts are the small, hyphae are the large, dimorphic includes both. The small ones are the ones that usually responsible for meningitis, while the large hyphae are the ones that can cause parenchymal and vascular occlusion. And the commonest type of yeast is Candida and Cryptococcus. The hyphae, the commonest type is Aspergillus and the mycosis. And the dimorphic, the commonest is the Cleomycosis. So we agreed to classify them into small yeasts, into large molds and hyphae, and into dimorphic. Let's look at the yeasts. Yeasts are the small pseudomycetes, and the commonest is Cryptococcus. They usually result in meningoencephalitis because of their small size. So they are small, rounded, irregular in shape, but they are not like the hyphae. So these are common picture of the yeast. Another picture, small rounded structures of the yeast. And again here also the yeasts. The hyphae are different. You may have large hyphae, you may septate hyphae, i.e. straight ones or one that can branch and can divide. So those ones, the large ones, they usually cause the abscess and the granulomas. And the septate or the branching usually can cause infarction. Both of them are large, as we agreed. So this is a picture of branching hyphae. And you can see the hyphae within the lumen of vessels, in the brain, and all the structures that it can invade. Look at this here, hyphae. Here and here. Same thing, still we are looking at various forms and pictures of the hyphae, whether they are straight or branching. Here it's very much branching, here too. And here is one hyphae inside the blood vessel, inserting itself inside the blood vessel. Sometimes the hyphae has sort of rounded end like this. So this is the hyphae, and then it has this rounded end as this. You look at this picture here, you say how beautiful that is, but fungi are not beautiful structures. They look beautiful here in this picture, but they are awful kind of enemies to the human being. Dimorphic means that you have both the small size and the large size, the rounded one and the hyphae together. So you'll have both features. Now, sometimes you have rare fungi, and they have various names that are appearing because of the use of immunosuppression and the use of transplants. So this causes rare types of fungi to appear. And mind you that some fungi, they act like a communal and or common structures in our mucosa and gut. This is one of the rare types of fungi, Clodophilia fora pantiana. A very funny name, but it is a name for this kind of rare fungus causing brain abscess. What about fungal CNS? We're not going to deal with the fungal infection in the lungs and the skin. We'll concentrate on the fungal CNS infection. This is an important slide. The incidence has been increasing over the last 3 decades. And look at the numbers. The number of fungal infection was 2 to 3 in the 70s, 80s, came up to 5.1 in the 90s. And this is the area where we had the kind of pandemic that affected the world due to the AIDS virus, and raised to 6.6 in the year 2000, and then since then it has been increasing. And why? Because there is increase in the use of transplant, immunosuppression, and in the immunocompromised patients. So incidence has been increased in both the immunocompromised and the immunocompetent. People usually think of fungus infection affecting the immunocompromised. Wrong. It can affect the totally immunocompetent patients because they are there and they can affect it. And the commonest one is to affect a competent patient, immunocompetent, if you have diabetes. So the organisms can go into the sinuses, they can go through the blood, they can go from the lungs, and here we have the direct inoculation by surgery, by doing a spinal tap, by putting a shunt, etc., etc. That's why it can affect immunocompetent patients. And look at this, perineural spread of Rhino-cerebral mycosis. You can see the perineural spread into the cavernous sinus. Here it's the, of course, the trigeminal nerve. So again, it can affect immunocompromised patients. These are mostly affected, immunocompromised AIDS syndrome, or immunosuppressed by having whatever drug for that, or organ transplantation. And also some of the risk factors are to have malignancy, whatever that malignancy be. Also, if you have a collagen vascular disease, this is one of the risk factors. And for one reason or another, fungal CNS infection is associated with sarcoidosis and autoimmune disease. So in general, the risk factors to develop a fungal infection are chronic diseases, mainly diabetes, hemochromatosis, if the patient is having chemotherapy, intravenous drug abusers, and we know this from all the Hollywood films, or if people are abusing the antibiotics, and then the antibiotics would suppress the bacteria and flare up the virus, the fungus. Also, if you are treated with steroids, and these are important, if you are giving your patient steroids, beware. Steroids can cause fractures, it can cause osteoporosis, it can cause diminished immunity and fungal infection. And don't go to the pharmacy and just get antibiotics on your own, because if you abuse them, you will get the fungal infection. Intravenous catheters, CVPs and others, severe brain injury, burn injury, recent radiation, or warfare treatment in radiotherapy. These are risk factors. In infants, sorry, low-weight infants are at risk, malnutrition, if the patient is having hyperalimentation, and this is important, if the patient is having surgery. And in our case, the shunts. I am anti-shunt. I fight severely for so many years, for decades and decades against the shunts. You should not put a shunt unless it is necessary, and you have to put it, and this is really is needed in very, very few cases. There is abuse of shunts in the Middle East. People put shunts for colloid cyst, for pineal tumor, for craniopharyngioma, and for the fun of it. So we are producing generation after generation of people who can do shunts without thinking that they are doing very harm to their patients. External drains, skull-base surgery, head injury, all these are risk factors for fungal infection. Of course, as I said, immunocompromised in this patient in bone marrow transplantation. And you can see following the bone marrow transplantation, this patient developed invasive aspergillosis. Here, this is a paper about immunocompetent patient developing intracranial aspergillus infection. And it's serious infection. Fatal aspergillus brain abscess in immunocompetent. So immunocompetence, please remember this. Immunocompetent patient and immunocompromised patient both can be affected by fungal infection. Again, this is immunocompetent patient with developing this cerebellar aspergillosis, immunocompetent individual, causing cavernous sinus mass, cavernous sinus thrombosis, and death for most of the cases. Fatal brain infection, again, in an immunocompetent patient. And look at this subcutaneous collection of the fungal infection, fungal abscess. In children and in adults, both are the same. People think also that fungal infection doesn't affect children. It does, especially when they have a shunt. So please think 10 times, million times before you put a shunt, simply because you cannot do a certain procedure that you put a shunt. I really have seen bilateral shunt being put for a colloid cyst. And to me, this is a crime against the humanity. So in general, BP shunts, about 27 to 33 shunts are inserted every year. That's in the States. It can malfunction in 40 to 50%. 40 to 50% malfunction, revision of a shunt, revision of upper end of the shunt, revision of the whole shunt, lower end of the shunt. So lots of residents, the only surgery that they can do is a shunt. Thereby, when they see a colloid cyst or a craniopharyngioma or intraventricular tumor or pineal tumor, they just put bilateral shunt because this is the only surgery they can do. And those shunts infection rate is still very high in the whole world, 10 to 30% in the first few months. This is early, and then it can happen late. This is a paper about shunt infection, and this group published in the World of Neurosurgery 2012. In this period of time, 58 were reported of fungal infection. So not only you get shunt infection by bacteria, you get shunt infection by fungus. And then you and your patient are in trouble. Candida meningitis associated with shunt infection in adults. So whether children or adults, you can get the shunt infection and abscesses and death due to the fungal infection of CNS. Is it rare? Look at these. I collected it for you. Fungal infections of ventricular shunt, histoplasmosis diagnosis and treatment. And look at the series. How many cases have been reported with fungal infection? And that is not looking into the bacterial infection, and that is not looking to the complications of undue surgical procedures done for children in the Middle East. Still, a shunt is being abused totally in the Middle East because there are so many mediocre surgeons who cannot do surgical procedure, and they cover this by putting a shunt. So again, meningitis can happen not only after a shunt, can happen after any surgery. Here, this is cryptococcal meningitis after transnasal, transfoidal pituitary microsurgery. So whenever you do surgery on the brain, on the skull base, on the spine, you may get a fungal infection. So this is a paper to show this. Again, you can get fungal from burr holes, and usually burr holes are given for the most junior member of the staff. Go and do the burr hole. They don't take the precautions. They don't shave. They don't scrub well. Scrubbing is in the Middle East is just for 1 minute or 2 minutes. This is not enough. You have to scrub for at least 10 minutes, proper washing, and then you go and shave the area that you need to do. Maybe you don't want to shave, but you clean properly. So cerebellar aspergillosis after burr hole. Imagine this, doing a burr hole for subdural hematoma to be complicated by fungal infection. So the CNS infection can be classified into either it is rhino-cerebral, meaning from the nose to the cerebral, or pure intracranial. So rhino-cerebral 50%, 50% are purely intracranial. Let's look at them one by one. Rhino-cerebral. It's called rhino-cerebral mucormycosis. And note this, 50% of all mucormycosis occur in diabetes mellitus. I hope if there are any of the panels endocrinologists, they can enlighten us about why this is happening. This is one of the complications of diabetes mellitus. 70%, 50 to 70% occur with diabetes. And it is classified into stage 1, 2, and 3, and 4. Is it in the nose, or it went to the orbit, or did it go to the cavernous sinus, or did it go intracranial? So when I say stage 4 rhino-cerebral, it means that it started in the nose and ended in the brain, and in between it has passed maybe through the orbit and the cavernous sinus. So this is to show you that this is carotid artery seen here. Here it is thrombosed because of infection coming from where? Coming from sphenoid and ethmoid sinuses. Again, same thing here, sinuses, ethmoid going into the orbit, ethmoid going into the orbit. Same thing here, ethmoid with fungal infection. Same thing here, sphenoid, ethmoid. Here is involvement of the carotid, as I mentioned. And also in here that you can see this fungal infection from sinuses, frontal sinus. Even if it goes to the orbit, sometimes you have to do enucleation. And this is most traumatic for the patient and his family. Involvement of the cavernous sinus. Involvement meaning that there is a thrombosis of the cavernous sinus, a proptosis. In diabetic patients, usually this is fatal. Thrombosis of the internal carotid too. So you can see the cavernous sinus, here CT, here MRI, being involved with this fungal infection. Now let's see which sinuses are mostly affected by the fungal infection. And I hope we have in the panel also a few of our ENT colleagues, ENT surgeons, who can also enlighten us about the reason for this. So ethmoid is the commonest, followed by maxillary, followed by frontal, followed by sphenoid. Sinonasal fungal infection in immunocompetent, again affecting here mostly the ethmoid, but then it goes into the maxillary sinus. Here maxillary sinus, here in the orbit, here ethmoid going into the orbit, and so on. Again, craniocerebral fungal infection of sinonasal origin, that's the ethmoid, going into the maxillary and causing cerebral abscess. Fatal outcome of Rhino-orbital-cerebral mycomycosis. Don't belittle, don't underestimate fungal infection. Fungal infections are mostly fatal if you don't treat it properly, if you don't take care about it, then it will kill your patient. Affecting the orbit, affecting the mucosa of the mouth, the dentist, the hard palate, going into maxillary sinus, ethmoid, and going everywhere. Another sinocranial aspergillosis started in the sinuses and went everywhere. Rhinocerebral mucormycosis starting in the mouth, going into the orbit, into the maxillary sinuses, and so on. Another sinuses infection spreading into the brain. So you have to have a close relationship with the ENT surgeon so that you can cover this topic. Rhino-orbital-cerebral mucormycosis started here, causing massive thrombosis of the cavernous sinus and the internal carotid artery, ending in massive infarction. And this is, of course, infarction in the middle cerebral territory. Rhino-orbital from the maxillary sinus everywhere into the brain. Notice this. This is the place where the fungal infection live, basal ganglia. They are different from the bacterial infection, who likes the junction of the gray matter and the white matter. So if you see abscess here, most likely this is bacterial. If you see it deep, this is most likely a fungal. Same thing invasive sino-orbital, affecting the orbit and the sinuses, ethmoid being the commonly affected. Again here, sinonasal origin in immunocompetent patients and thrombosis of the cavernous sinus. So you can see that. And from there, it can go into the brain. Usually this is fatal. If you see such picture, this is decimal prognosis. Once they do this. Here, ethmoid, sphenoid, sinus origin of the fungal infection. As we said, that 50% are sino-orbital-cerebral, or it is purely intracerebral parenchymal. The presentation here is either they are presenting like acutely rapidly fatal illness, which is dangerous, meningitis, encephalitis, you name it, or it may go into a chronic phase where it will form a granuloma. Let's see the pure intracranial fungal infection. Again, we repeat, fungi for the brain or for the body as a whole, it can affect the immunocompetent and the immunocompromised. Which virus, which fungus is the commonest affecting the brain? Candida, aspergillosis, and the mucormycosis. These are the commonest ones. So they can cause meningitis, meningoencephalitis, ventriculitis, they can cause abscess formation, they can cause granuloma formation, and we have not to forget the mycotic aneurysms and the thrombosis that these fungi can cause. And due to the encephalitis, meningitis, ventriculitis, then you will develop hydrocephalus and you may develop myelitis. We are at or facing a very critical, serious disease. And I hope the message would go home, how much important that we need to take care of that. The fungal infection is as dangerous as the COVID. So this is the presentation, as I mentioned, meningitis, encephalitis, abscess formation, granuloma, strokes, spinal infection, hydrocephalus. The commonest affected areas of the brain: frontal, temporal, parietal, anterior cranial fossa, middle fossa, cellular, paracellular, posterior fossa is rare. So these are specimens from people who died with fungal infection. Would this small thing cause death? Yes, it can. Fungi effect is very tremendous and very, very unpredicted. Look at this. Abscess stage formation, cerebritis into a stage of abscess here. The worst thing is to have a fungal infection causing ventriculitis. In 99% of cases, you cannot eradicate it and it will end in death. Once you see ventriculitis, it's a very, very bad prognostic sign. Can cause infarctions and the basal ganglia and the midbrain and the pons, etc., etc. And it can cause basal meningitis, which can cause obstruction of the CSF and hydrocephalus. Pictures of meningitis in this patient. Usually here you can see that the dura is thickened. Encephalitis in these patients with the fungal infection. Again, the ventriculitis. Once you see this with contrast, it's most likely that the ventricles have been invaded. Hydrocephalus, secondary to meningitis, encephalitis, you name it. Abscess. So we mentioned meningitis, encephalitis, and abscess. Abscess, just like any other abscess, bacterial, TB abscess, amoebic abscess, you name it. So you have to be careful how to try to differentiate between these. And I will go and mention a few of the differentiating examples. I mentioned one, that the fungal infection usually is in the basal ganglia, while the bacterial infection usually goes into this junction of the white and gray matter. But here it's against the rule for two reasons. It is here it is in the posterior fossa, and here it is superficial. So there is no rule for that. CT and MRI showing these abscesses, which could be single, could be multiple. And once they are multiple, you'll have a dilemma of diagnosis. Then you will go into histoplasmosis and sarcoidosis and tuberculosis and so on. Again, don't forget that children as adults can get these fungal infection without a shunt. Fungal infection in pediatric patients causing this abscess in the pons. Multiple abscesses. Candida glabrata. Again, cerebral abscess, multiple. Here you are at loss. What kind of lesion is this? Are we dealing with a protozoa, or are we dealing with a parasite, or are we dealing with what? Fungal pituitary abscess. Would you imagine? Would you have a pituitary abscess? Yes, you can have pituitary abscess. You can have pituitary metastasis. Metastasis of lung into the pituitary, and metastasis from the fungal infection of the chest into the pituitary, just localized in the pituitary. And what would you diagnose? Pituitary adenoma. But this was not a pituitary adenoma. This was a fungal pituitary abscess. Is it rare? Look at the literature and how many cases have been reported of pituitary fungal infection. And let alone, we are not describing the bacterial infection, just the fungal infection. As we said, either it is fatal, acute, meningitis, etc., or it goes into a chronic form, and then we'll talk about granulomas. So this is one of the granulomas. Most of the lesion is a granuloma with a slight or small amount of an abscess. And the commonest cause in granuloma is aspergilloma. Examples in the literature of fungal granuloma by aspergillus like this. You go and you find a very solid lesion with little pus in it, because it went into a chronic form of granuloma. Intracranial fungal granuloma, study 90 cases over 18 years. Can it cause vascular complications, this fungal infection? Of course it can. We mentioned that it can affect the cavernous sinus, invade it, causing major neurological deficits and thrombosis of the internal carotid artery, usually ending with death. And here again, the cavernous sinus involvement. It can cause like this hemorrhage, infarction, all sorts of things when it goes into the brain. This is because of the vascular effect of this fungal infection. Here you can see this hyphae in the lumen of a blood vessel. So this is how they can be transmitted. This is how they can spread. And this is how they can cause thrombosis. Also, if they invade the wall, they can cause mycotic aneurysm, subarachnoid hemorrhage, and death. So here you are, you can see the fungus in the wall of the vessel, like this, and then we are speaking about mycotic aneurysms. So mycotic aneurysms are aneurysms caused by fungal infection, causing massive subarachnoid hemorrhage, intraventricular hemorrhage. And if one deals with them as one deals with the ordinary sclerotic aneurysms, I had the chance of operating on 2 mycotic aneurysms in my life. You just feel at loss how to deal with them because their wall is so friable, and one of them ruptured during surgery with me. So here you are, subarachnoid and intracerebral hemorrhage, usual complication of rhino-cerebral mucormycosis. This is serious. People think twice before putting shunts, before doing surgery, which is unnecessary, before not really washing your hands properly prior to surgery. Isolated pontine infarction due to rhino-cerebral mucormycosis. Mucormycosis causing skull-based osteomyelitis. And you can see it's evident. Again here showing the aneurysm that it can cause, and then the invasion of the brain tissue. Mycotic aneurysm causing this hemorrhage. Again here, mycotic aneurysm caused by fungal infection. العلامات جاية على الكلام. Paper from fungal aneurysm due to the fungal infection causing this aneurysm, and here it's causing, look at this carotid being straight going a normal size, and then at the junction where it gives the ophthalmic artery, it's blocked completely. Mycotic aneurysms, again, due to fungal infection. Okay, it's all right. Yes, that's fine. What about the radiology? How do they look, these fungal infections? Let me say this to you. Fungal infections of the central nervous system are almost always a surprise. Like all the infections, they just come suddenly, unexpected. And one thing I have to tell you this, there are 2 or 3 steps ahead of you. So when you do CT or MRI to a patient and look at it, by the time you look at it, if you look at it now at the end of the CT or MRI, actually the patient has gone 2 or 3 steps deteriorated within this very short period. And we need to know that you have to differentiate them from other abscesses, myogenic abscess, tuberculosis, and from neoplasm, and from other lesions, as we said. Let me show you some of these very misleading cases that you need to know the differential diagnosis. This is intraventricular cryptococcal cyst masquerading as Racimo's neurocysticercosis. Here you are, and here you are. Again, this is an abscess, fungal abscess masquerading like a brain tumor. Here, an abscess masquerading like anything, and it turned out to be an amoebic abscess, amoebic encephalopathy. Look at this very unusual thing that I came across in literature, atypical fungal granuloma of the sphenoid wing. Who would say that this is not anterior clinoid meningioma? This was a fungal granuloma. So prepare yourself for the surprises of this fungal infection. Again, this is histoplasmosis masquerading like a tumor. This is fungal infection masquerading like a pituitary tumor. Aspergillosis of a sphenoid sinus masquerading like a pituitary tumor. So the list can go on and on. And again, who would not diagnose this as either a meningioma or a vestibular schwannoma of the CP angle? It was a fungal infection. So what are the radiological tests that you need to do for your patients? Of course, you need to go to the basics. You need to do chest X-ray because fungal infection can affect the lungs. And you do sputum cultures. You may need to do bronchoscopy, biopsy, etc. And then you go for radiological testing. CT can show you the sinuses. It can show you the abscess. It can show you the infarction. But mainly the value of the CT is to show you the sinuses. As we mentioned, MRI is a very useful tool, and it can show you various information about this fungal infection. Look at this here, huge abscess. Again here, massive shift midline, massive edema. And the shape here is not the usual. So this is CT, and this is how it looks on the MRI. I'm putting various sequences of the MRI. Again, I have to mention this, that posterior fossa, fungal infection, be it encephalitis, meningitis, or a mass, is very rare. So as we said, it could be single, it could be multiple. And this is a very important thing to mention. The black turbinate sign, a finding of nasal mucormycosis. If you see this black sign, then you are dealing with fungal infection. And this is due to devitalization of sinonasal mucosa caused by the fungus. What about diffusion? Can it help? Can the diffusion sequence help me differentiate between a fungal infection, a bacterial infection, tuberculosis and abscess? The answer is no. I could not. I looked into the literature well, and there are various reports that at the end of the day, to me, you cannot rely very much on diffusion. Let me take you through that. Here you can see this. This is abscess. Is this fungal? Is this bacterial or tuberculous? Well, this shadow here is showing the hyphae of the fungal infection. And there is restricted diffusion here. So then you say, well, in fungal infection, there is restricted diffusion. But this is not in all the papers I came across. This is one of them. Let's see the other. The periphery is restricted, but the center, there's no restriction. You can see there is no restriction while there is a restriction here. Totally different conclusion from the previous papers. Increased diffusion. All right. Or again here, increased diffusion. But then another paper say decreased diffusion. So which one do you believe? I think you may come across all these varieties of the MRI in fungal infection. But let's give some clues. If you see a focal lesion, most likely you're dealing with aspergillosis. If you see multiple lesions, then most likely you're dealing with candidiasis. If you see disseminated, then you are dealing with the cryptococcosis in general. These are just general lines. What about spectroscopy? Can it help? Again, like diffusion. I looked into any evidence in the literature that spectroscopy would help. The answer is no. And I came across this. Spectroscopy is the same in all the three kind of abscesses and in all three peaks corresponding to the amino acids, lipids, and lactate. So this is the same curve. This is a pyogenic abscess. This is a fungal abscess. And this is a TB abscess. They look the same. So don't count much on this dosimetry. Can it affect the spine? The answer is yes. Spinal mycosis is part of the affection of the CNS. It's mostly extradural than intradural. It will end with deformities. It will affect its stability, and it will present itself mainly like paraspinal abscess. And some of the MRI images you can see. What about lab? You need to do the general lab tests, CBC, LFT, KFT, urine analysis, and then you need to do the serological test to detect antibodies to the fungal antigens, antibody titers, the complement fixation, the CSF assay of titers, the assay in form of ELISA or CF for immunodiffusion, and of course the PCR tests. So if you want to diagnose this, you need to have a macroscopic detection of the microorganisms, whether in the brain or in the CSF. And you have to do the assays that are mentioned for the blood and for the CSF. Sometimes you have to count on a tissue removed from the brain to reach to the diagnosis. That's much difficult it is. Different assays. If you look into part of the fungal wall, like the galactoman assay or glucocam, detect part of the PDG in the serum of CSF. if you are looking for a component of the fungus wall. So if you do a series of study, and most of the time you cannot take a CSF by a lumbar puncture because of increased intracranial pressure, you may just get it during craniotomy or whatever. But if you look at CSF through craniotomy, not lumbar puncture, it may be clear colorless, may be turbid, you may have normal white PCs, you may have increased white PCs, protein is usually increased, and there is dominance of lymphocytes. But again, sometimes you have a neutrophil predominate in certain types of fungal infection. So again, that's not very helpful, like any abscess. So you need to see the gram stain of the CSF. But remember that hyphae are rarely seen in the CSF, and it is very difficult to culture the fungi in the CSF. So the definite diagnosis of a CNS fungal infection is either you isolate the fungus from CSF or the brain, or you get the antibodies. This is the culture. Remember that CSF cultures are positive only in 25, 70, 30%. The treatment is, if you don't treat it, it's fatal. If you just don't follow your patient properly, if you don't diagnose well, then your patient will die. If you are treating your patient well in the right time, and if the patient is immunocompetent, I'm not mentioning the immunocompromised because immunocompromised results are worse, but if you have immunocompetent and you treat them well, cure or chronic suppression of the infection is 75%, which is good. Immunocompetent with meningitis, it goes down 40 to 50%. Immunocompetent with an abscess, only 25%. So when you see a fungal abscess in immunocompetent patient, the survival is only 25%. And these whole figures will go much, much lower if you have immunocompromised, immunosuppressed patients. What about surgery? It has a place, yes. Whether you do the endoscopy for the sinuses, whether you do craniotomy, transsphenoidal, orbitotomy, or just bare hole for biopsy. Here is a paper about endonasal transethmoidal drainage of cerebral abscess. So they went through the nose without opening the dura because this was an extradural abscess. Again, rhino-cerebral mucormycosis with a brain abscess drained by endoscopy endonasal. Again, here they make this point: don't open the dura, because if you open the dura, you will transmit the infection and disseminate it. If you have a patient with a shunt, this is the major dilemma. You have to remove the shunt, and if you remove the shunt, you have to put external drain. External drain is a foreign body, so you are actually establishing the infection. So you need to do repeated LP or lumbar drain. So it is a real dilemma. And this is again to speak about do not put a shunt, please, unless it is really necessary. There is abuse of shunt procedure in the Middle East. And every single resident listening to me knows this fact, knows that this is the surgery that they do because they cannot do anything better. And when you give the medication, the medical treatment, the antifungal drugs, you give induction and then you consolidate your treatment and then you maintain it. So the commonest drug, antifungal drug, is amphotericin, amphotericin B. Other drugs like fluconazole or intracranial. Let's go back to the amphotericin, which is the commonest drug used in the fungal infection. Drug resistance is rare, it's very effective, but not for those in the brain. Why? Because they have poor crossing for the blood-brain barrier and because they have renal and hepatic toxicity. So they came up with the idea that if we do lipid formulation of amphotericin, we will minimize toxicity to the kidneys and to the liver. And they produce these amphotericin B lipid complex, amphotericin B colloidal dispersion, and amphotericin B liposome dispersion. These are the drugs that are now available in the market. They can be given oral, IV, or intrathecal. That's what I said, because we want to overcome the blood-brain barrier, we came up with this lipid formulation of the drug. Flucytosine is another drug that's given with the amphotericin. Side effects being bone marrow affection. The triazoles like fluconazole, intraconazole, they have lower cure rate than amphotericin, but mainly they are given as maintenance. So you start with amphotericin and then you end with the triazoles. I looked into literature and I found new antifungal drugs. One of them is intraconazole. One of them is voriconazole. One of them is pneumocandines and papillocandines and cytokinase. And again, if we have any of our colleagues, the infectious disease people, please come over and join us and tell us what you think about these drugs. Sometimes you just need to give medical treatment. You don't need to go for surgery. And this is an example, a paper speaking about massive intracerebral aspergillosis like this being treated only with medication, amphotericin, without any surgery. 2 cases of cerebral aspergillosis treated with medication without surgery. Now, in the last 10 minutes, I will speak to you about my experience with these fungal infection. Between 31 years of experience, I had only 12 cases, and surprising surprise, 10 of them were males and 2 were females. So fungal infection, for one reason or another, in my series is more in males, which goes with the general literature. 3 cases, we'll go through them quickly. Case 1, this is the group of the patients that I mentioned. This is the first patient, a young patient from Libya who came with this picture from Libya. So obviously that it is a fungal infection with extradural extension. He was not treated there. By the time he arrived here, it was too late. And you can see when we did CT scan, look how much the ethmoid is widened, and that's why I explained this hypertelorism, the wide distance between his eyes. So the CT scan showed this immense ethmoidal infection, but then the CT showed extension of the abscess into the CNS. Again, when I looked at this picture, I thought this is not compatible with life, but this patient was lucky. All this abscess was extradural. None of it was intraparenchymal. I could manage to drain all of that and give him medical treatment. This is post-op. With medical treatment, he went home nice and dry. Case 2. This patient he's a 52-year-old pain patient with no diabetes, with no hypertension, no AIDS, and he's just a busy businessman who went to hospital because he was a little bit confused with some weakness in his left arm, and they have done this, and they sat on it for one reason or another. They thought this is a glioma, and will give steroids. So they add insult to the injury by giving steroids because, as I said, the steroid would decrease your immunity. Of course, you can use steroids in fungal infection just when you are operating, but not just like that. So this is the lesion that they diagnosed as a glioma. And his chest, abdomen did not show anything. So this is a surprise. This is 30th of May, 2020. This is a recent case during the COVID disasters. When he came to me on the 3rd of June, having spent so many days in the other hospital, his abscess has gained strength and it went very, very aggressive. And when he came in, he was drowsy, he was sleepy. If you just squeeze him hard, he may raise his arm, but he would not respond to you. We did all the what we call routine infection control for any patient with this kind of illness, HIV, HCV, and sugar, etc. Let me show you now the surgery of this patient. Again here, I will go through. Can you see the movie? John, can you see the movie?
Yes.
Good. So this is just showing the thrombosed cortical veins. And look at this huge granuloma in his motor parietal strip that needed to be taken out. Very tough. It's a granuloma, and that's because he was not managed well, and this infection went from the acute phase into a chronic granuloma phase. So all this is the wall of this granuloma, and as I said, as I'll show you now, very little pus material that one can get. But thrombosed veins, there were lots of them. So here we are removing this granuloma, which is hard. Scissor is barely able to cut through. We continue removing these kind of tissues one by one, and then we go into the depth of the abscess. Again, here I want to show you that I want to cut this thrombosed veins and nothing will happen because it's totally thrombosed. So that's why when I saw this in the theater, I thought this patient will not make it. This is incompatible with life. The size of the abscess, this thrombosis, and look at the pus here. Very ugly pus, very, very ugly. So, this is the pus that we produced in this test tube. And this is the growth of the hyphae in that pus. Not only hyphae, but also yeasts. So both yeasts and hyphae. The histopathology reported by my colleague, Dr. Abu Farsakh, who is American board pathology, showed us these slides. A granuloma with central necrosis, as you can see. Immunostaining showed the cells to be CD68 positive for histocytes and GFAP positive for astrocytes. And Ki67 is positive in inflammatory cells. And again, the field is histocytes and leukocytes, inflammatory cells. You can see hyphae and yeast together in the same slide, like in here. And thrombosed veins, as you could imagine, and we have seen it through the film. I was mistaken. I thought this patient is gonna die. In fact, when I took him to theater, one of his pupils were dilated. So I told his family, with all these pictures that I've seen, and with the thrombosed veins that I've seen during surgery, your patient is not gonna make it. I was mistaken. He did make it. This is the first post-operative day MRI, showing that we have done a good job by excision of this abscess, wall, or granuloma completely. I started to improve gradually, opening his eyes. This is the dressing. Here is coming to follow up in the clinic, still having left-sided weakness, facial weakness. Another visit, he could barely stand and he could barely elevate his arm. Last MRI, and this is very, very lucky patient, 21st of January, this MRI showed complete resolution of this granuloma, and he can walk on his own. His facial is gone. So even if the case looked dismal, this was really encouraging for me to put your effort, put your heart and soul into helping the patient, and let the results for the Creator, for God to help. The last case, and then we'll be finished taking your questions. This patient came to me from Iraq, 67-year-old male patient. Here he is diabetic. Last two patients were not diabetic, but this patient was a diabetic for 10 years. And in his past history, he had dental abscess drainage a month before he came from Iraq. He, in Iraq, developed behavioral changes, memory loss, severe frontal headaches. So they have, again, sat on him, but he rapidly deteriorated. Usually in the Middle East, once a patient have behavioral changes, memory loss, he is diagnosed as Alzheimer's disease. And this is, again, a kind of thing that is being abused in cases that incompetent, mediocre doctors diagnose this without actually looking deep into the matter. There are certain criteria for multiple sclerosis. There are certain criteria for Alzheimer's, but those mediocre medical people or surgeons, they don't know about it. So he became very much worse, unable to walk, incontinent urine and feces, became unresponsive. And then he was brought. Then they have done the MRI in Iraq. It was poor quality MRI, but again showing these multiple lesions in the frontal area. Again here, some ventriculitis here, multiple lesions. And this is his chest and ultrasound of abdomen. So on arrival to Jordan, he was moribund. His Glasgow scale was 9, barely arousable, very, very unresponsive. And our MRI showed that the pathology has progressed. Remember, abscess, fungal, bacterial, tuberculous is always 3 steps ahead of you. Once you see this, it has already progressed. And the most important point was this ventriculitis. And ventriculitis means bad. It most of the time, not almost every time, it is just not compatible with life. So ventriculitis, even in the 4th ventricle and the lateral ventricle and in the 3rd ventricle. So it was there giving us a bad omen. Again, we've done the routine infection. This is the routine infection control in Jordan for anybody coming from abroad, whether he's going for appendicitis or for dental extraction. And it is a routine infection control if you are suspicious of certain things. Then you can do the AIDS and others without consulting with the patient for their own safety. Let's see the surgery now. It's not opening. Again, I'm gonna go through that rather quickly. This is the wall of the abscess. You can see the pus inside. The abscess is made of many, many areas. In many areas, the abscess was found. And the pus inside and outside. It was tough in some areas that I had to use the ultrasonic aspirator. And you can see that even cutting it is very difficult. It was really, in some areas, very, very tough. It says pus, but mostly it was a granuloma. My aim was to remove the granulomas and to reach into the ventricle and drain them from the pus and do wash, etc., so that I can help this patient recover. So you can see here, and just go back. This is the junction of the granuloma with the floor of the anterior cranial fossa. So somehow the infection went from his dental extraction into his sinuses and then went intracranially. Here I'm inside the ventricle, and there is pus there. We just reached now. Huge mass. Again, I'm showing you here the scissor, the large scissor that I don't use in neurosurgery, but I had to use in here because of the toughness of the wall and because of the chronicity of this granuloma. Multiple septated abscesses. Here we are inside the ventricle, and you can see the ventriculitis inside the wall. It does not look healthy at all. So what I did is to drain the pus, wash, 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 until you got this pus inside here, and it may come into contact with the choroid plexus. So I've done my best there, and we just concluded the surgery. Okay. I thought this patient is not gonna make it, and I was right. The previous patient, I thought he's not gonna make it, and he did make it, but this patient did not make it. As we were in, we had CSF from the ventricle, and it was turbid with white PCs, neutrophils, and lymphocytes. And histopathology from my colleague, Dr. Farsak, showed multiple fungal abscesses with the granuloma formation. And this is the culture. The stains showed aspergillus, the hyphae. The first day post-operative CT scan looked nice. The CT looked nice, but the patient has improved a little bit. Glasgow Coma scale was 13. But then on the 10th postoperative day, he deteriorated progressively and had the Glasgow Coma scale of 3. And that is the value of diagnosing ventriculitis. He was really moribund, and we did MRI then. Nothing unusual except for the ventriculitis business. There was no increased intracranial pressure, but his ventriculitis killed him. So he developed ventricular tachycardia, and he passed away. So this patient was unlucky, and he could not make it. With this, I finish, and I'm happy to take your questions and answers, questions and comments. And if we have anybody on the panel that can come forward and speak to us, either ENT surgeon or endocrinologist for the diabetes, or histopathologist, your comments are more than welcome.
Okay, Radab.
Yeah, thank you, Dr. Subeh, for this very uncommon topic to be discussed. Yet it's very, very important and was very informative for us to be more aware about this fungal infections, how fatal they could be, yet not to lose hope in some cases, and do our best in every case, individualized, and just let the creator do his job. So I know, Dr. John, if you pick any questions from the panelists.
Sure. Anybody have any questions or comments to make?
I've seen Dr. Hassam Abu Farsakh there. If he's there, can have his comments on the histopathology.
Okay.
Are you there, Hassam?
Dr. Omar, I can speak?
Yes, of course. Please.
Thank you, Dr. Ibrahim, for good lecture, for Professor. I see 3 questions and 1 note, please. The first one is fungal, maybe cause of aneurysm. Okay, the cause of the aneurysm, as we tell that. And GBM, like before we diagnosed, it is post GBM, I think, is aspergillosis equal. You see? Third one, pre-fungal infection we can take routinely at any things the risk factor, not and give anti-fungal. Third one, the note by note, please. Third one, fourth one. At 1988, I when medical school the second year, I read a book of Lebanon doctor. He tells that many malignant tumor, the cause of the because of the tooth infection. He treats them and they treated. This book at 1988. Thank you very much for you, Professor Brian.
Let's start with the comment. It's a very funny comment that brain tumors are caused by the dental infection. If you treat the dental infection, they will disappear. I've never heard of this at all in any other lecture or meeting or whatever, so I just dismiss it. As for your questions regarding the fungus causing aneurysm, yes, and this is a well-known category called mycotic aneurysm. The hyphae or the yeasts are in the wall of the blood vessel, and it will cause weakness and it will cause aneurysm. And as I said, I had the chance of dealing with 2 aneurysms, mycotic aneurysms in my life, and they were very, very dreadful because they just bleed when you're just doing dissection. So they can rupture in you. In fact, one of the aneurysms that I've done ruptured on me during surgery. So mycotic aneurysms are reality. The second question that you asked about the people diagnosing JBM or glioma while it is fungal. And this is the idea of presenting such a paper, for people to raise their suspicion and look at things in a different eye and look always into differential diagnosis. People in the Middle East are so in rush. Any picture, this is low-grade glioma, high-grade glioma, without really going into the list of differential diagnoses. I teach my residents. There are lists of differential diagnoses that you have to go through, not for the exam, but for your future life. There are differential diagnoses. Is this lesion congenital or is it acquired? If it is acquired, is it inflammatory? It is vascular, it is infectious, it is tuberculous, it is malignant, it is benign. If you go through this list, every time you look at MRI, you will not miss. But if you just look, oh, this is whatever, this is the...
Put in mind, this is a diagnosis.
This is wrong.
But please, I take your permission to give in an Idlib area, there's a residency and specialist to take this lecture to them. No problem from permission?
No problem, no, of course.
Thank you very much for you. Thank
Pleasure.
you, Prof. Thank you.
Dr. Abu Farsakh, are you around? No.
Well, Dr. Subeh, regarding, if you don't mind, I have a question.
Sure.
Regarding that mycotic aneurysm that ruptured with you during surgery, were there any consequences in the operations, or did you take any certain precautions post-operatively?
Sure. Rupture of aneurysm intraoperatively is the most frightening experience you come across. And I came across rupture during clipping in about 5 aneurysms. And what I used to teach, fortunately, none of them was lost. None of those patients with rupture was lost because I was well prepared. Preparing meaning proximal control and distal control. Preparing meaning that you are anticipating this to happen and you are prepared what to do. You have your temporary clip ready to clip the to do the proximal control. So aneurysm, the rupture, and the time you are not expected them, in a time which is not expected. Like I have one rupture of aneurysm during induction of anesthesia. Patient was conscious, he became unconscious. I did not continue the surgery. I took him to the CT scan, massively bleed, so just put him on a ventilator, recovered well, and then I clipped his aneurysm. So aneurysm can rupture on induction, during craniotomy drilling, on dissection of the Sylvian fissure at any time. You have to be prepared, and preparing is expecting, and preparing means that you are ready for it to go through. You will go into hypotensive. You have asked your anesthesia to prepare your hypotensive anesthesia, and so on and so forth. So it's a long story. We'll not turn this lecture into aneurysm surgery lecture.
So that means, doctor, that you dealt with it as any ruptured aneurysm.
Yes.
But not
But
specific
I just
to-
wanted to make the comparison between a mycotic aneurysm and the atherosclerotic aneurysm. This is, in the atherosclerotic, I put actually the bipolar on the wall of the aneurysm so that it will shrink. This is a trick I learned during my training. I don't go to the fundus, I go into the lateral wall, and I put my bipolar so that the aneurysm would shrink. You don't do that with the mycotic aneurysm because they have very, very friable thin wall.
There is no need to put any topical antifungal on the parenchyma.
No, absolutely not. You have to treat the patient as mycotic and give them the medical treatment.
Okay, thank you.
Pleasure.
Okay, I see Dr. Zayden there. It's not like you to be quiet. Dr. Zayden, are you there? Well, he may have stepped away. Okay, sorry, Deb. Okay, any more comments, questions for Dr. Sabea?
I can see Dr. Hussam Farsak and
Yeah, I see his name, but he's not there. Maybe he's not there, maybe he left or something.
Yeah, I see him there, but he's asked, you want to speak to him, Dr. Sabea? Okay.
Well, I asked him actually to join us so that he can make his comments, and I asked our endocrinologist to join us to show how diabetes is very dangerous. Most of these patients of fungal infection, they had diabetes. So people should not underestimate the effect of diabetes on the health.
Okay, is the endocrinologist here? I don't know.
No, I cannot
No.
see any.
Oh, okay. Okay, any other comments, questions, or just want to say hello?
I see, or only I asked Dr. Brahim, Professor Brahim, about the CSF and the serum, lympho or nitro. Nitro at serum and CSF is lympho increase?
No. Both of them lymphocytes are more, but the neutrophils sometimes can increase in the aspergillosis.
Aspergillosis. Okay, thank you very much. Okay, thank you.
Hello.
Go ahead, Hossam. Go ahead.
Hello, Hassan.
Sorry, there is connection problem.
No problem. Can you give us your input about the histology of these fungal infection?
Yes, I would like to elaborate more on the fungal changes in the brain. The brain tissue usually has histomorphological changes that are not the same as in the other body tissue. This is important point for the pathologist to recognize, because we search for fungus, and it's very important to search for fungus in each and every case that has neutrophils or lymphocytes in it, and they can present without granulomas. They can present as dirty necrosis and can present in infarcted areas, and can present when there is granulomas and when there is infection or infarction. So the pathologist has to really have a very wide very low level of suspicion of of fungus, because it makes a whole lot of life and changes to the management of the patient. The last patient, the second patient that was presented with Dr. Brahim Speh, actually I suspected it because of mainly of the dirty inflammation that's present, and we do special stains to detect the fungi. The fungi, in many times in histology, they are not discoverable on routine H&E stains. So pathologists really has to search for them. And we have special stains that can highlight different types of fungi. Some fungi may be seen by H&E and you confirm them by other stains, but some fungi are not really, cannot be seen by H&E. So we do at least two important stains. One of them is GMS stain, and the other one is PS stain. But also we do other stains like Giemsa or other immune staining to detect the fungi. So it's very important for the pathologist to really widen his suspicion when he sees any inflammation, because anything that the pathologist can can say in the microscopy diagnosis can really help in the cure of the patient. Second case really is a good example when the patient presented with the vascular thrombosis, and this was the main presentation in the pathology. But because we search on every case, I think the patient took very good management, and I discuss usually cases thoroughly with Dr. Ibrahim Sbeh. We have very good communication. Whenever I really suspect that there is a microorganism, I always talk to him and ask him to do a further test or further cultures, and I convey the message clearly to him what are the possible diagnoses. One important thing I think for the clinician to know, we as a pathologist, we cannot make the exact fungus genus or the exact name of the fungus. For example, we may not differentiate easily between mucor and aspergillus, although there are some changes. But the exact subtype of the fungus has to be done by microbiology. We only raise the suspicion or confirm that there is a fungus, and culture has to confirm it. So this was my important points that I would like for the clinician and for other people to know what are the benefits and what are the limitations of the pathologist when he looks at a slight suspicious for fungal infection.
Thank you, Hassan. Thank you very much.
Okay, Verdad, do you see there's a question in the panel? Do you see that question there? From Napoleon, you see that?
No, there's nothing in the chat or.
Oh, okay, let me just read it from Napoleon, Dr. Sabea. In the last case, would you consider just a cyst drainage as total treatment?
The last case.
Yeah.
No, definitely not. This patient has major increased intracranial pressure, multiple abscesses, ventriculitis. Although you feel that the prognosis is dismal, yet you have to go for excision and not drainage. I've never, ever did the drainage of pus. I always go for removal of the abscess with its wall. The wall contains organisms, whether it is bacterial or fungal or whatever. So those who just take a specimen from the inside of the abscess and then treat patient with medication is very, very wrong. The only indication for this is that the abscess is periventricular and you are afraid to cause rupture into the ventricle. So you can actually drain it by stereotactic biopsy. But for any abscess, for any lesion, benign or malignant, go for radical excision. Even if I have a JPM, I go for radical excision. And radical excision in gliomas is to remove 85% to 90%. Just to take a biopsy and send the patient for radiotherapy is wrong. Just to take pus and give the patient antibiotic is wrong. So many wrongs in the practice of a neurosurgery in the world that we need to actually put it right.
Very good. Okay, Dr. Sabea, unless there are any comments, closing comments or questions.
I agree with Dr. Sabea. Thank you for this. And take a biopsy only of any tumor or any abscess is very, very wrong. This is my training, and during study, I'm now private clinic.
Good.
Thank you.
Okay, very good. Okay, Dr. Sabea, do we have a topic for next week?
Yes, yes, I prepared a few very unusual intradural spinal lesions. So I'm going to move from the brain into the spine because I have a very, very good, very unusual cases of spinal lesions. Intradural, I don't like to deal with the extradural spinal lesions. I don't deal with them. This metastasis, etc. I deal with only the intradural spinal lesions. And I have a few of them that would interest people to hear about.
Okay, very good. Let me just tell people what's going on. This week, we have Dr. Goela, who you know, I'm sure.
Naturally, yes.
He's giving a lecture with UA's Grand Rounds in China. That's being translated into Chinese and Japanese simultaneously. What do you think of that, Radab?
That's fantastic.
Yeah, and you know, Dr. Sabea, the neurosurgeon's giving the translation because, as you know, it's pretty technical stuff.
Absolutely, yes. I've listened to that, but I have to tell you this: lots of it is lost in the translation. Even if the translator is a neurosurgeon, lots of information is lost in the translation.
Really?
I think, have you seen the film Lost in Translation?
Yeah, I have seen the film, actually.
Famous film. So sometimes even if the translator is a neurosurgeon, sometimes the information is lost.
Okay, well, it's a start. Okay, and then we have one from Egypt, Dr. Sabea. Samuel Morsi's put together a good lineup with Dr.
Yes.
Goel once again, Dr. Borba.
Louise,
Dr.
yes.
I think you know probably most
Yeah,
of these
yeah,
people.
Michael Lawton.
You know, you know all those
them all.
people.
Yeah.
So that looks like a good one. So
Yeah.
otherwise, we'll see you next
Wednesday, 7 o'clock Jordan time, 5 o'clock GMT.
That's right. And Verdad, welcome to the team.
Thank you,
very much,
Dr.
Amin.
John. Thank you, Dr. Spike, for this
Thank you.
rare and important
Bye-bye.
topic. Thank
Okay.
you.
Bye-bye.